We'll cover some more review of orthopedic surgery here. If you haven't seen the first set of questions, you might want to go back and look at those. This is picking up where we left off. So question 11, a 61-year-old man is on the surgical unit recovering after rod fixation following a femoral shaft fracture sustained after falling off the roof of his house. Despite being in pain, he has otherwise been arousable. On post-op day 3, the nurse comes into his room to get regular vitals and notes that he's unconscious, pulseless, and unresponsive to painful stimuli. Pupils are fixed and dilated. A purpuric rash is noted on his arm. Which of the following is the most likely cause of death? A. Pulmonary embolism from DVT. B. Massive hemorrhage. C. Septic shock. D. Fat embolism. Or E. Anaphylaxis. Alright, I'll give you time to pause it here. And the answer to this one is D, fat embolism. So with this patient, he had a fracture of the long bone, particularly of his femur, and that is a major risk factor for fat embolism. So any kind of fracture of the long bone, and really when we're talking about the long bone here, we're talking about the femur. So fracture of the femur, that is a major risk factor for fat embolism. Now, typically, patients with fat embolism will have some kind of symptoms before they die, but in some patients you can have sudden death from fat embolism, so no real particular symptoms jumping out. But it is important to note that fat embolism is a cause of sudden death in patients who have sustained long bone fractures, particularly femur fractures. All of these other things are possible causes of death after surgery, but fat embolism is the most prominent cause of sudden death after femur fracture. So this is how to determine fat embolism syndrome. So like I said, most of the time with fat emboli, you will have symptoms. You don't just jump into sudden death, however that is possible. But some of the things to look for mainly are the petechial rash. You can also see chest x-ray changes. Now, you might not be getting a chest x-ray unless the patient has symptoms. So, of course, looking for tachycardia, tachypnea, things that might trigger you to get a chest x-ray. Hypoxemia, another thing that may trigger you to get a chest x-ray, fever, and confusion. So you can see how these play into fat embolism syndrome by their score. So just having a petechial rash puts you right on the verge of diagnosing fat embolism syndrome. The score is 5 or more. So petechial rash in and of itself should be a major clue. And indeed, this patient did have a petechial rash, so it is possible that he might have had that petechial rash prior to and was not diagnosed with fat embolism syndrome when he could have been diagnosed and therefore wound up dying due to misdiagnosis, which is not tremendously uncommon. So very important when you have patients with femoral fractures to keep an eye out for this. Question 12. A 14-year-old girl presents for her high school physical. On examination, you note asymmetry as the right scapula is higher than the left, while the left hip is higher than the right. On neurologic examination, she has a normal gait. There are no sensory abnormalities. She has +4 out of 4 strength in both upper and lower extremities, and +3 out of 5 reflexes, patellar, Achilles, and bicipital. Spinal X-ray reveals 30 degrees of right-sided angulation. Which of the following is the most appropriate next step for this patient? A. Watchful waiting, follow up in 6 months. B. Physical therapy. C. Bracing. D. Surgical spinal arthrodesis. Or E. No treatment necessary, normal variation. All right. So this is something that you'll see quite often, especially if you work with children. And the answer to this is C, bracing. So this is a patient who has scoliosis. Scoliosis starts during, for the most part, with the exception of congenital scoliosis, scoliosis starts at puberty and it continues to worsen until the growth plates fuse, which is usually for girls around 17, 18, 19 years old. So if patients have scoliosis and it's not being treated in some manner, then it will continue to worsen, and so it's very important to pick it out as quickly as possible. Now, that having been said, the treatment is going to vary based on the degree of angulation. And commonly what's used is this little device called a scoliometer. However, you can also look at the x-ray and make that determination. A lot of times the radiologist will make the determination of the degree of angulation, and so that can help you determine what treatment you want to use. If it's a mild scoliosis, generally we consider that under 20 degrees. You can just do observation, so that would be watchful waiting, follow up in 6 months. If it's a patient between 20 to 45 degrees of angulation, moderate scoliosis, you would do bracing, especially if there's a lot of growth remaining, which would be true in this patient. She's only 14 years old. If she were 18 years old, maybe you could get by with watchful waiting. And then if it's more than 45 degrees of angulation, which would be severe scoliosis, you would go ahead with surgical therapy, surgical spinal arthrodesis. So it's very important to know the different treatments, and I would remember those numbers that I gave you: less than 20 degrees observation, 20 to 45 degrees bracing, and 45 degrees or more surgical spinal arthrodesis. It's also important when you have a patient with presumed scoliosis to rule out any kind of neurologic signs. It is possible to have something called neurologic scoliosis, and so you want to rule out any kind of upper motor neuron signs. And so we do rule that out here, in as much as she has a normal gait, she doesn't have sensory abnormalities, and she has normal reflexes. So an abnormal neurologic examination with the presence of scoliosis suggests neuromuscular scoliosis, which is different from just pubertal scoliosis, and therefore the treatment is going to be different, and we're going to want to get an MRI to investigate that further. But for the most part, most patients who have scoliosis just have the typical adolescent scoliosis, and we'll be able to treat them either with watchful waiting, bracing, or arthrodesis. Physical therapy is always useful, but it's not. We don't just use that by itself. The bracing part is the most important part for this patient's therapy, given that she's between 20 and 45 degrees of angulation. So here are your signs of scoliosis. This is quite a young patient. So usually scoliosis presents at puberty. So this patient would have the congenital scoliosis because she's a lot younger. She looks like she's probably only about 6 or 7 years old. But things to look for on physical exam, just from looking at them in a standing position, would be the uneven shoulders, a curvature in the spine. If they're a lean patient, oftentimes you're going to be able to see that curvature, and then unevenness in the hips. And scoliosis affects about 1.2 to 3% of the population, so this is very common. You will see this. Here's an x-ray, and this is looking from the posterior side. As you can see here, this isn't situs inversus. This patient's heart is on their left side, but we're just looking from the back here. And you can see a significant degree of angulation in this patient, even more so in this patient. This patient here on the right would be a candidate for arthrodesis. You have about 45 degrees of angulation here. And the problem with scoliosis, the major complication, is that it can lead to pulmonary compromise, just because the angulation from the spine can compromise the thoracic cavity. All right. Question 13. A 3-year-old boy presents with his mother for his annual physical. He's playful and interactive, but his mother complains that his legs don't look right. Patient appears as such. You're often going to get parents who are concerned about how their kids are developing. And so you're not going to get 3-year-olds coming in, driving in their tricycles and talking about their own problems. Right. When asked about his diet, his mom says that he is not a picky eater and he particularly enjoys milk and orange juice. There are no significant juvenile disorders in the family history. No signs of child abuse are present. Which of the following is the most likely diagnosis in this patient? A. Physiologic genu valgum. B. Physiologic genu varum. C. Blount's disease. D. Vitamin D resistant rickets. Or E. Dietary calcium deficiency. Alright, the answer for this question is B. Physiologic genu varum. So this is a patient who has genu varum, as you can see by the curvature of the legs. It's bilateral genu varum. However, this patient is only 3 years old, and there is always a normal period of both genu valgum and genu varum that you need to be aware of in growing children. So genu valgum can present in patients, in children between the ages of 2 and 6. So if you have knock knees in a child 2 to 6, that's normal. It's physiologic. Now, it's not normal in as much as all patients have it, but it's normal in as much as if the child is aged 2 to 6 and they have knock knees, then it's nothing to worry about. If that occurs after age 6, if it's still present, then it's pathologic. Now, what we saw in this patient was genu varum. This has a smaller window of normalcy. It's normal between ages of 3 and 4. Now, if the patient is older than age 4, then it is abnormal genu varum. So genu varum is bow leg. And the way I like to remember it is, this is genu varum, right? You've got more spaces in between the knee, more space, so more air between the knee. Genu varum. So, genu is just the Latin word for knee. The causes of genu varum, if it's pathologic, are rickets, vitamin D resistant rickets, which is different, and Blount's disease. Now, rickets is a deficiency of calcium or other nutrients, including vitamin C. Vitamin D resistant rickets is a congenital disease in which you can't respond to the vitamin D that you're getting in your diet, and this would be something that the patient may have a family history of. So we saw in this patient that they're getting, the child enjoys milk and orange juice, so certainly not a candidate for rickets, and there's no disease, similar disease in the family history. Regardless, the patient's only 3 years old, so we would consider this to be physiologic genu varum. But it's never a bad idea to ask about the patient's dietary history, about the family history, etc. Rickets and vitamin D resistant rickets can also cause genu valgum. Now, if the patient was pathologic, so if this was a 5-year-old patient, for instance, then your next step would be to get an x-ray, and what you would be doing is you would be looking for osteomalacia. And osteomalacia would be just sort of a darkness in the bones that indicates that there's less calcification inside the bones, and that would be indicative of rickets or vitamin D resistant rickets. And the way you could differentiate those two would be whether or not they're getting an appropriate diet, or if they are. If they're getting a bad diet, it would be rickets. If they're getting good diet with vitamin C and calcium, etc., then it's probably vitamin D resistant rickets. Blount's disease is a diagnosis of exclusion. So that would be if you don't have rickets or vitamin D resistant rickets, but you have the genu varum in the pathologic stage. Okay, so good to remember these ages. 2 to 6 for physiologic genu valgum, 3 to 4 for physiologic genu varum. Question 14. A 7-year-old boy presents to the ED after falling off his bike. On physiologic examination, you note a child in severe pain and distress guarding his right elbow. When he lets you see his elbow, after you promise you won't touch it, you know that it is swollen and mildly erythemic. Further physiologic examination reveals bilateral abrasions on the palm of his hands, which he says are from falling down. There are no gross abnormalities of the forearm, nor of his left extremity. Sensation is intact bilaterally. Radial pulse is weak. Elbow x-ray has been ordered. Which of the following is the most likely diagnosis in this patient? A. Shaft fracture of the humerus. B. Elbow dislocation. C. Supracondylar fracture of the humerus. D. Dislocation of the radial head. Or E. Colles fracture. All right, the answer here is C, supracondylar fracture of the humerus. You need to be very, very, very familiar with this very, very, very common fracture in children. And this is pretty much only in children, and this is due to the fact that children have ligamentous laxity because they're growing, and so the ligaments need to be relaxed in order for the bones to grow, for the ligaments to be able to facilitate that growth and to be able to grow with the bones. But what happens with supracondylar fracture of the humerus is that you fall onto outstretched hands, an outstretched arm, with hyperextension of the elbow. Now, us adults can't hyperextend our elbow normally. Our ligaments are matured. But children can, with enough force, hyperextend their elbow. And if you have hyperextension of the elbow, that puts you at risk for this supracondylar fracture of the humerus. Now, we don't know based on the spoken history that the patient fell on outstretched hands, which if it's an adult, they may be able to tell you how they fell, maybe even a child. But where the hint comes is that the kid has abrasions on the palms of his hands, which makes sense. If you've got a kid that was riding his bike and he fell down onto outstretched arms on his hands, then he's probably going to get abrasions on his hands. So you can probably deduce from that he fell on outstretched arms. So very important to know the supracondylar fracture of the humerus caused from falling on outstretched arms and hands. Very common in children. Now, with Colles fracture, it would be more likely due to falling onto the wrists rather than the hands. And the shaft fracture of the humerus is generally accompanied with radial nerve palsy, in which case we would see numbness of the dorsum of the hand and weakness of the wrist extensors. With elbow dislocation, we would see a much more gross abnormality of the elbow. And then dislocation of the radial head would not be seen in an injury like this. Okay, so the supracondylar fracture of the humerus, just to recap, is a fall with a hyperextended arm at the elbow. There's an increased incidence in children, particularly 5 to 8 years of age, so this kid is 7 here, due to ligamentous laxity. Symptoms are pain at the elbow, swelling, guarding, irritability, abnormal neurovascular exam. However, they don't need to have that. The abnormal neurovascular exam would be only if they have some kind of neurologic implication, which there isn't always neurologic implication. Swelling is often present. The physical examination should be focused on neurovascular complications. So how do we test for neurovascular complications? We test the integrity of the arteries that can be affected, which we're looking for distal pulses, so checking the brachial artery. And we're looking for for numbness of the hand or weakness of the wrists. And it's better to just check for numbness of the hand because the patient's going to be in a lot of pain, and so you may get a false positive if you're checking for strength at the wrist. So check for numbness of the hand. That would be checking your radial, ulnar, and median nerve. And then, of course, always checking for swelling. Now, we're checking for neurovascular complications, and the reason we're checking for neurovascular complications is to see if there's any possible compartment syndrome. Now, swelling in and of itself, and I should say swelling in the forearm, there's always going to be swelling in the elbow, but significant swelling in the forearm up to the wrist would be a sign of compartment syndrome. And so that's something that we're very concerned about with supracondylar fracture of the humerus. Remember that there are certain fractures that are particularly associated with compartment syndrome, and those are supracondylar fracture of the humerus, tibial fractures, and forearm fractures. Now, the best initial step, assuming that there are no neurologic or vascular complications, is going to be an X-ray at the elbow. If the distal pulses are absent, so if there are actual vascular complications, if we're not able to get those distal pulses, then we're going to get an emergent arteriogram. And in most patients who have compromised distal pulses, they are going to need surgery because you're going to have to do some arterial repair, and so the vascular surgeon is going to do that. But for the most part, it's just going to be really important for you to remember that children falling on outstretched arms and hands are at high risk for this supracondylar fracture of the humerus, especially if the pain is in the elbow, and that it's extremely important to check for possible signs or precursors to compartment syndrome. So here's the supracondylar fracture of the humerus. The condyles are right here, and this is the end of the shaft. So it's slightly dislocated as well. Question 15. A 62-year-old woman with a history of chronic lower back pain presents to your clinic complaining of left leg pain. She says that she gets intermittent leg discomfort that radiates down her hamstrings. On physical examination, she has +4 out of 4 strength of her right hamstrings, but +2 out of 4 of her left. Her right patellar reflex is +3 out of 5, but her left patellar reflex is absent. Vertical leg raise elicits stereotypical pain. I should say left vertical leg raise elicits stereotypic pain. Her neuromuscular examination is otherwise normal. MRI is performed and shows herniation of the vertebral disc. Which of the following discs is most likely herniated? A, L2, L3, B, L3, L4, C, L4, L5, D, L5, S1, or E, S1, S2. Okay, the answer to this one is C, L4, L5. Now, it's important to remember when discs are named, they're named after the vertebrae that they're in between. So the L4, L5 disc is between L4 vertebrae and L5 vertebrae. But the nerve, if the disc is herniated, the nerve that that disc would affect would be the superior nerve, so L4 in this case. So L2, L3 would affect L2, L3, L4 would affect L3 nerve, etc. So those are the spinal nerve roots that it would affect if they become herniated. Now, unilateral symptoms always suggest disc herniation or osteophyte impingement, which are both complications of degenerative spine disease. And that's a normal manifestation of aging. So common locations for disc herniation are particularly L4, L5, and S1. So the L4, L5, the L5, S1, and the S1, S2, which were all answer choices in this question. This is a great figure. This isn't mine, but this is a great figure to remember because L4, L5, and S1, being the most common locations, are going to be the most likely to come up on any test or in real life, for that matter, when you have a patient with a herniated disc. So if the nerve root that's affected is L4, so if it's the L4 or L5, then you're going to get pain that goes down the side of your leg, down your leg, and you're going to have numbness in your upper thigh. The motor weakness would be extension of the quadriceps, and the reflex that would be diminished would be the knee jerk. That would be the patellar reflex. Screening exams would be a squat and rise. What you're doing here is just checking for extension of quadriceps. That's basically what that screening exam is doing. And this is what we had in this patient. L5, so the L5-S1 disc. In this case, you would have a very similar distribution of pain, this just because it's affecting roots going to the sciatic nerve. So you'll have pain down the posterior leg and lateral leg, and numbness down the lateral leg. So here we have dorsiflexion of the great toe and foot that's going to be affected, and the reflexes, there's none. So we don't have any reflexes that will be affected from the L5 S1 disc herniation, and so it's mostly going to be knowing that the weakness is going to be at the foot. With the S1 impingement, you're going to have roughly the same distribution of pain, but you're going to have numbness at your foot, and that's not seen in any of the other ones. So S1, you have numbness at the foot. You also have motor weakness of plantar flexion, which would be tippy toes. So these patients would have difficulty walking on their toes. That makes sense. And the reflex that would be diminished here would be the ankle jerk reflex. So with L5 and S1, good way to tear these apart is L5 is dorsiflexion, so they're going to have a hard time walking on their heels. That's what you're doing when you're walking on your heels. S1, they're going to have difficulty walking on their tippy toes, and that's what you're doing when you're plantar flexing. And then L4 is the patellar reflex. Okay. Question 16. A 37-year-old woman presents to the ED after having fallen off her ladder. She says that she fell on her hands, but now has severe pain over her right wrist. There is obvious gross deformity. Here you go. This is her wrist. I don't know if that's nail polish or what on her nails. Don't worry about that. So here's the deformity here. X-ray of the forearm is ordered, as it always should be when you have a patient with a gross deformity. And here it is. So this is a lateral X-ray, and this is just a table that she's on or something. All right, now that you've seen this, which of the following is the appropriate diagnosis in this patient? A. Colles fracture, B. Monteggia fracture, C. Smith's fracture, D. Galeazzi fracture, or E. fracture of the radial shaft. In case you want to see this again, I'll just go back. And the answer to this one is A. Colles fracture. So Colles fracture is caused from falling onto the wrist on the dorsal side. So when you fall onto the wrist at the dorsal side, it's going to apply force. Colles fracture is caused by falling on the wrist on the ventral side. So right here. If you fall onto your wrist on the ventral side, it's going to apply dorsal force. So posterior force, however you want to call this. It's going to apply force that way, the way this arrow is going. And so the dislocation of the part, this part here, is going to be dorsal. So this patient fell onto her wrist right here. It caused a break, and this stronger piece here, because it's stronger because it's attached to more bones, it dislocated dorsally, and then this ventral part is the part of the radius. So that's Colles fracture. Smith's fracture is the opposite. So in this case, you fall onto your dorsal wrist, and it moves the distal piece ventrally. So it's just the exact opposite of a Colles fracture. Just memorize it. These names have nothing to do with the anatomic positions. So here's a Colles fracture. We already saw it. So the dislocated segment, which you can just remember is the distal segment. The distal segment is going to be dislocated dorsally. So that's a Colles fracture. So here is your distal segment, and it's dorsally dislocated. And then here's a Smith's fracture. It's a little bit harder to see, but it's right down here. Of course, you're always going to want to have more than one view for any of these, but the Smith's fracture is a ventrally dislocated segment. The other two forearm fractures that were referred to are the Galeazzi and the Monteggia's fracture. The Galeazzi's fracture is a fracture of the distal 1/3 of the radius, along with dislocation of the distal radial ulnar joint, DRUJ. So here we have two views. We have a lateral view, although it's kind of twisted up here, so I could fit this. So here you can clearly see that, one, there's a fracture of the distal 1/3 of the radius, which is right here. You also have a disruption of the distal radial ulnar joint. The distal radial ulnar joint is just where the radius and the ulna come together. And that would be right here. So any kind of disruption of that would be a dislocation of the distal radial ulnar joint. The Monteggia's fracture is kind of the opposite of the Galeazzi fracture. So the Galeazzi fracture was the distal 1/3 of the radius. The Monteggia's fracture is a fracture of the proximal 1/3 of the ulna. Again, you're just going to have to memorize these names to the anatomic disruption here, because they really don't make any sense with these names. But Monteggia's fracture is a fracture of the proximal 1/3 of the ulna. And then with this, you would also have a dislocation of the radial head. So you can see here, fracture of the ulna right here. And again, you'd want to have two views here. I couldn't find the other view that corresponded to this particular x-ray, but this is this lateral view. Here you see the fracture of the ulna. It's a total fracture here. And then clearly a dislocation of the radial head to the point where it's actually causing some... I'd like to see what this patient looked like, but this is obviously causing gross deformity because the soft tissue is deformed. Okay. Question 17. A 3-year-old presents to the ED with her concerned mother. Mom says she was getting her ready for preschool and putting her jacket on when suddenly she screamed, and since then has been crying and pointing to her right elbow. The mother is frantic and says that this was all of the sudden and she didn't see any injury at all. On physical examination, you note a toddler in extreme distress guarding her elbow, holding it extended, pronated, and close to her body. There is no swelling or visible deformity. Which of the following is the most likely diagnosis? A. Septic arthritis. B. Nursemaid's elbow. C. Tendinitis. D. Supracondylar fracture of the humerus. Or E. Dislocation of the distal radial ulnar joint. Okay. The answer to this one is B. Nursemaid's elbow. So this is a very common injury in young children, especially toddler age, the age where parents are going to be kind of pulling them by the arm, getting them ready. And this is not uncommon at all, and this is definitely not child abuse. So this is the kind of... These kids traditionally come in with their parent absolutely dismayed, and they have no idea what happened. And it makes sense that they have no idea what happened, because it's usually a very, very, very mild trauma that causes this. So something as simple as pulling the child's arm out of their jacket sleeve, or if the kid is not coming with, trying to pull the kid's arm to get them to come with and follow them. This is a coincidental injury, and it is absolutely not indicative of child abuse. Most of the time, the parents are absolutely dismayed at what's happened. However, it appears very severe because the kid is in absolute mortifying pain. And so with Nursemaid's elbow, the typical pain that you see, of course, is pain in the elbow, which whenever you're dealing with a child, especially a child that has a limited vocabulary, you're not going to ask them where it hurts. You're going to tell them to point to where it hurts. And they will point exactly where it hurts, and it will always be at the elbow when it's Nursemaid's elbow, of course. Other things that we see with Nursemaid's elbow is that they will generally, if they do move their elbow, which a lot of them, because it hurts there, they're not going to want to move it, but if they do move it, they'll move in any direction except for supination. So most of the time, they're going to be holding it slightly extended, but always pronated. And this is very typical of Nursemaid's elbow. This is a classic case of Nursemaid's elbow. So Nursemaid's elbow is a dislocation of the radial head, but it's just a slight dislocation in as much as it slips underneath the annular ligament. So what you have is a parent or a caretaker that is holding the kid's hand and just maybe applies a slight force to that radial head, and it's just enough to get the radial head to kind of slip a little bit out of the annular ligament. And remember, the ligaments in children are relatively lax and not really strong yet because the child is continuing to grow, especially in really young children. And so this is perfectly possible from just mild trauma, coincidental trauma, not child abuse. So this is what happens here. You get the slippage of the radial head out of the annular ligament. And here you can see that the radial head is coming out of the annular ligament, and part of the annular ligament is going to get stuck between the radial head and the humerus. And what you would do for these patients is, because this is caused from a sudden pulling or axial traction, what you're going to do is you're going to do the exact opposite to treat them. And it's generally pretty easy to do this treatment. You should be familiar with this, at least for clinical medicine. I wouldn't worry about it for the USMLE, other than knowing what Nursemaid's elbow is. But for the for real life, it's good to know how to treat Nursemaid's elbow. And that is, first off, rule out fracture. And that's usually pretty easy to do just because with fracture there's going to be a significant level of swelling, and there'll also be some kind of incident that happened, some kind of precipitating incident that the parent will be able to remember. But what you're going to do is just apply inward radial traction. So you're going to hypersupinate the arm, and the kid's not going to like this. But you're going to supinate the arm, and that's going to get the radial head into the appropriate position, and then you're going to apply inward force at the wrist, and that means you're just applying proximal force in the proximal direction, so the exact opposite direction of how the injury happened. So arrow would be towards this way, proximally, and you'll apply a force in that direction with hypersupination, and what you should feel is a little bit of a snap. And after that, maybe after a little bit of residual pain, the pain will be gone. And you'll be Superman or Superwoman because you'll have made this kid's day. So this can be a really wonderful thing as a physician to be able to treat because it's instant gratification. Okay, question 18. A 14-year-old girl presents to the ED complaining of severe left toe pain. This has been going on for the past 12 hours since she woke up. She denies any injury to the toe. Vitals are blood pressure 125/80, heart rate 105, respiratory rate 15, temperature 101.9. Physical exam reveals this. Okay, so here's her toe that's in pain. And I'll just add to that if you feel it, it's going to be warm. You can't tell that from the picture. So labs reveal. Oh, I guess I indicated that. Okay, left toe is swollen, erythematous, and warm to touch. Labs reveal increased white blood cells and elevated ESR. She was seen most recently 2 weeks ago for pharyngitis, which has since resolved. Which of the following is the next step in the management of this patient? A, foot x-ray, B, foot CT, C, bone scan of foot, D, needle aspiration of the affected bone, or E, admission with IV nafcillin. All right, the answer to this is C, bone scan of the foot. So the reason we're not getting a foot x-ray here are twofold. One, when you have a patient with acute osteomyelitis, which is what this is more than likely, just for two reasons, because this was acute pain with no injury following a streptococcal infection. When it takes generally about a week after the symptoms come on in order to have an abnormality on x-ray. The bone scan will show abnormalities much sooner. But it's also, we're not going to get an x-ray because there was no injury to the toe to begin with. So that makes a fracture unlikely. So bone scan of the foot is the best diagnosis, best initial diagnostic test for acute osteomyelitis. X-ray is not, because it's not going to show changes until roughly a week into the illness. Now, the most accurate test, and what we're going to ultimately have to do, but what we prefer to wait to do because it's an invasive test, is a needle aspiration of the affected bone. So the best initial diagnostic test is bone scan, which if it comes back positive, then we're going to get a needle aspiration of the affected bone. And that's for two reasons. One, because it's part of the treatment. We're going to want to get the pus out. And two, because we want to get cultures, because the cultures are going to tell us how we're going to treat the patient after we give empiric therapy. So treatment, the standard is surgical drainage, which we do when we're doing the needle aspiration, and then IV antibiotics. The cornerstone is a semi-synthetic penicillin, so something that has something that is effective against Staph aureus. So nafcillin, clindamycin, etc. You can use vancomycin if you are practicing in an area where community-acquired MRSA is common, but don't worry about that for the USMLE unless they tell you that it's a MRSA infection. For the USMLE, you can assume that you're not in an area where community-acquired MRSA is common unless you're told otherwise. So a semi-synthetic penicillin. You can add a third-generation cephalosporin, something like cefuroxime or ceftriaxone, if it's a patient that's younger than 3, or if it's a patient that has not ever been vaccinated to Haemophilus type B. You can consider adding rifampin if there's joint symptoms present, and you should cover Pseudomonas if the patient is immunocompromised, or if there was penetrating trauma in association with this illness. So if this patient had stepped on something or something like that. As usual, it's going to be important to reassess the antibiotics after culture results. The most common cause of acute osteomyelitis is Staphylococcus aureus, so you're usually not going to have to change the treatment. However, in limited cases, you will, because the cause will be different. But majority of the time, it will be Staph aureus, and so your nafcillin, clindamycin, vancomycin, any of those would be fine. After discharge, you can you should continue the patient on oral antibiotics, which would just be the oral equivalent of whatever they were on IV for about 2 weeks. And that is it.